In this video, I'd like to talk about long anterior zonules and their impact on cataract surgery and how recognizing this specific sign can reduce the risk of complications. So we all have that routine case during cataract surgery where you have excellent dilation, and peripherally you can see the insertion site of the zonules. And this is absolutely normal, nothing to be concerned about. Well, long anterior zonules is a specific entity where the zonules, they don't stop here. They actually insert more anterior, and it can be a very subtle sign that you may not recognize at the beginning of surgery. If you don't recognize this condition, it can lead to a lot of complications. So what do I mean by that? Well, let's assume you start the case. So here's our well-dilated pupil, and the surgeon doesn't recognize LAZ, okay? Well, again, you're going to notice it here because I'm using a marker, but in routine surgery, these zonules are very thin. So the surgeon will start the capsulorhexis, and I'm just going to pretend like the surgeon's completely oblivious to the insertion sites of these zonules. Well, as the surgeon was making the capsulorhexis, he or she was in the process stripping away all these zonules. Now, usually with this condition, there could be a few fibers or there can be many. And as you're stripping fibers, you're going to induce zonulopathy. Also, one other thing to be aware of is as you're making the capsulorhexis and as you reach a fiber, the risk of an extension increases. So as you go across here, if you don't notice the fiber, there's a high risk of extension. Same thing here, here, and here. So if you don't recognize this condition, you will certainly strip zonules, and that can lead to subsequent issues during phacoemulsification. But also, not recognizing the fiber, you also have an increased risk of run out. And as it runs out, of course, it can track back to the posterior capsule. So what is the management? What to do if you see these kinds of cases? Well, the first step is recognition. So what I do is for all my cases, at the very beginning, I take a split 1 to 2 seconds just to make sure that I'm not seeing any of these long anterior zonules. But let's assume we do. So here's a case where we've got long anterior zonules. How do we approach this case? Well, let's just make it a little bit easier for this specific case. Well, you're at the mercy of where they attach. You have to make the capsulorhexis where the edge of the capsulorhexis does not meet the edge of the long anterior zonule. So in this case, if I'm going to make the capsulorhexis, I'll start here and make my way around and delineating to ensure that I'm not within that region here. Now this topic can get complicated. What if we're dealing with a multifocal lens and we want a wall-centered rhexis? This can be challenging. So it's really important to recognize this. Otherwise, like I said, you're going to strip zonules. There's a high risk of extension. So the take-home point is recognize it and get in the habit at the beginning of every case. It's just to take that 1 to 2 seconds, see if there's any long anterior zonules, and then adjust your capsulorhexis accordingly. This may mean a smaller rhexis, depending on the extent. I hope you found this case to be useful, and thanks for watching.